Good evening, everyone. Many thanks for joining the session this evening. My name is Rajat, and I'm the manager at projects at DakshamA Health. I will be moderating this session for today. Moving on, about COPS, Community of Psoriasis Supporters works with the vision to build a strong nationwide patient voice platform for people living with psoriasis and those who support the cause. We are thrilled to have Dr. Krupa Shankar with us for this COPS event, which starts from today. Dr. Shankar is a highly experienced and respected consultant dermatologist currently working at the Mallige Medical Centre at Bangalore. With over 35 years of experience in the field, Dr. Shankar has numerous esteemed positions, including head of Department of Dermatology at Manipal Hospital, Bangalore, and postgrad teacher and examiner. He has also served as scientific committee chairman and has published over 70 index publications, one book on scoring systems, and 7 textbook chapters. Dr. Shankar has been invited to give over 300 lectures, and his area of special interest includes contact dermatitis, atopic dermatitis, acne, psoriasis, etc. He has received several awards and recognition for his work, including Dr. Sidapa Orientation IATVL, KN 2013. Dr. Shankar has wealth of experience and knowledge in the field and has graciously agreed to answer as many questions as possible. You can post your questions in the chat box or on our live Facebook stream, and our backend team will ensure that all questions are visible for everyone to see. We thank you for your participation and look forward to an informative and engaging session. So your expertise in the field would be greatly appreciated by our community. So we will be putting up slides by Dr. Krupa, and he will be explaining more on the session of misinformation around psoriasis. Vikas, can you pull up the slide, please? Full screen, please. Over to you, Dr. Krupa.
Can you all hear me?
Yes, sir.
Great. So I see that the weak connection is weak. So I'll let my voice go on, and as and when the connection becomes strong, maybe we can get to see each other as well. Shall I proceed?
Sure, sir. Sure, sir. Yes, sir.
Okay. So see, there is basically the DakshamA Healthcare is into medical care advocacy, and today's subject is advocacy in psoriasis. Now, when we talk of advocacy, advocacy has primarily to do with information which has to be forwarded to the various stakeholders. Now, who are the stakeholders in psoriasis? It's the same as any chronic disease, be it diabetes, hypertension, malignancy, psoriasis, or lupus. The stakeholders will remain the same. Just to remind ourselves, the stakeholders will be firstly the patients who suffer, then the doctors who treat them, and then we have the pharmaceutical industry who provide the means to treat, and then the medical instrument industry if it requires surgical intervention or things like this. People who make medical devices like intravenous catheters and so forth. And then we have the medical regulators such as the Indian Council of Medical Research, the CDSCO and DCGI, and these people. And then we have got government, the Ministry of Health and the like. Now, the point is, if we have to further the interest of a cure or at least a functional cure of a given disease, especially a chronic one, then we need to take all the stakeholders into consideration and look to see who needs to be informed what, in order to make the patient's life easy, the cure affordable, effective, timely, and a reality, in the sense that we will have people from a variety of backgrounds, languages, regions, degrees of access, urban, rural, and so on. And so an advocacy agency or an NGO or a group, or even if it were a professional disease advocacy agency such as the National Psoriasis Foundation, will need to take into account a large number of variations in the patient background, not to mention the differences in the level of the disease, to deal with the stakeholders who are all involved in this exercise. So having given this background information now, let us proceed on as to what are the sources of misinformation which could retard what we wish to achieve in terms of good, effective, optimal, affordable, reachable, accessible care for psoriasis. Since I've got a poor connection and I can't see my slides, I will ask Rachit Jain to read out one line and I will expand on that line. Let's begin with the first slide. In the first slide, I have mentioned my name and institution. Let's go to the next one.
Vikas, can you go to the next slide, please?
Yeah, you read out the slides because my bandwidth does not support it. Yeah.
So psoriasis advocacy stakeholders. So we have bullet points, which are the first point is patients. Patient as a stakeholder for psoriasis advocacy.
Continue. You go ahead and read the entire slide.
Yeah. So there are multiple stakeholders for psoriasis advocacy, and the list goes on like patients, doctors, pharma industry, laboratories, insurance companies, government, and regulatory bodies.
Yeah, so laboratory and insurance companies are the two things I left out in the list as I spoke. Let us go to the next slide.
So first, coming to the patients. Under patients, we have several bullet points. First comes education.
Yeah, just read out one point. Education. Now, if you want to talk of patient education, that is the title. If you go down, I have written out a website address, psoriasis.org. This is the American website of the National Psoriasis Foundation. By far the most reliable, well done, periodically updated, really committed group of people who run this National Psoriasis Foundation. We had doctors from India, in fact, even from Bangalore as well as Chennai and other parts of India who were advisors to this. Since we have got a large diaspora in the United States, it's a good site. I would very strongly and confidently recommend that such of you who wish to get information on psoriasis, don't put psoriasis in the Google search box. You better go to this site. Next one.
Right. The second is access.
Yeah, access in the sense that we all know that there are doctors all over the place. Not the next slide, the next point on the same slide.
Yes, sir. Autoimmune diseases for patient education.
No, autoimmune diseases. See, many a time when you read psoriasis on the net, it says that psoriasis is an autoimmune disease. That is because some antibodies against the corneocytes were discovered long ago, like in the 1960s. And for some reason, people call psoriasis an autoimmune disease. But the current understanding of autoimmune disease is something completely different. Currently, autoimmune essentially implies life or limb threatening. It can completely destroy some organs or joints and make life very, very difficult. So psoriasis by pathogenesis and our current understanding is not an autoimmune disease, it's an autoinflammatory disease, where a genetic component that impinges upon the immune system of the body has an important role to play. So if you read autoimmune disease while reading a description of psoriasis somewhere, please just skip that point. Let's go to the next point.
Incurable.
Yeah, so many a time when patients go to doctors, especially elderly doctors, people who have been in practice for several decades, they will say you will have to live with it. And our idea of a disease and its management goes back to the infectious disease era, where when you had an episode of illness, such as ecotonic or a bout of typhoid or malaria or something, and you were given medicine and you were cured. So in the past, a disease essentially implied an episode in the sense that you went there, you took a medicine in a stated period of time, generally running to a week or at best a couple of months, you are free of it and it is done, gone, finished, cured. Even long-standing diseases like leprosy, tuberculosis and all, we have achieved a cure of these, in fact, more than a decade ago. But there are a large number of diseases which inflict the population today where you can get only a remission. A remission is a disease-free period, okay? Or you can get what is called as a functional cure, in the sense that the disease continues to be present, but it doesn't trouble you anymore. For example, we have achieved functional cure in HIV. If you get HIV, you can continue to live for 30, 40 years. Okay, like this. So that's the next point I wish to make. It's not incurable, it's curable in the sense that it can be cured whenever it comes, as in psoriasis, or we can achieve a functional cure. That's another piece of misinformation that needs to be neutralized. Like the next point.
The next point is infectious.
Yeah, so psoriasis is not infectious. An infection elsewhere in the body, such as a sore throat, can precipitate psoriasis. But per se, if you touch someone with psoriasis, you won't get it. If you spend your time with such a person, live in a person's house, or happen to be his or a spouse, or parent or child, you won't get psoriasis by close contact or direct physical contact. That we need to know. Next.
So the next point is hereditary.
Yeah, it's like this. Many people are scared that it is not strictly hereditary, but there is a very strong genetic component. So the long and short of it is like this. If one parent has got psoriasis, the chance of the child getting psoriasis is in the range of around 14%. If both the parents have psoriasis, it's not inevitable that the child get it. The risk is in the range of about 40 to 50%. So there is a strong genetic component. Genes have a role to play, but that doesn't mean that if you have psoriasis, your children are bound to have it. This is a fear that many parents suffer. And sometimes they
So
ask
this
me,
was
neither of us have it. How did my child get it? Nobody in the family has it. How did my child get it? Defect is in the gene. There are about 9 psoriatic genes which have been recognized on the long arm of chromosome 17. They are called as the PSORS source genes. There are 9 of them. Probably more have been identified today. So it is a genetic disease, but it's not necessarily hereditary.
So this was one of the most asked questions, and you have already answered it. So I'm going to the next
What
point,
is that?
that is home cure. It was on this thing only, genetics.
Oh,
So the next
okay.
point is home cure.
See, many times patients ask me, can I do something at home by which I can control psoriasis? You can do very many things. And in fact, the doctors will also suggest a handful of things that you can or probably should do. But then doing your home remedies or natural remedies or the usual thing that we do for cold and cough, like boiling pepper in water or ginger, etc., adrak, somon, haldi and all, you can't really speaking get rid of psoriasis. Some very small, tiny patches may respond to some oil that you apply. Any oil should do.
Correct, sir.
But then when you've got extensive, moderate or severe psoriasis, you can't do it with home remedies alone. Sorry to say that.
Correct, sir. So the next point is permanent cure.
Yeah, like we said, permanent cure is what a patient expects when you go to a dermatologist. But then as a dermatologist, it's our responsibility to tell you what you need to hear, not what you wish to hear. Okay. So we don't even talk of a cure. We use the word remission, which is a disease-free interval. In other words, what we tell you is like this. Every time it comes, it can be cured. Once it is cured,
Correct.
there is no guarantee it will not come back. In all probability, it will. And once it is cured, how long will you be cured? On an average, 6 months to a year. If it comes again, what do? We treat till you are cured again. So if it is gone, please don't assume it is cured. If it comes back, please don't assume that you are disaster struck. So acquire an attitude of equanimity and know that you will deal with it as and when and to the extent it comes.
Correct, sir. So the next point is lifestyle changes.
Oh yeah, there are a few things that do impinge upon psoriasis. Number one, psoriasis is genetically associated with obesity. And I have seen many people who, when they shed a few kgs, actually the psoriasis patches disappear. Two, if you've got psoriatic arthritis, that is, psoriasis affects both the skin and joints. In up to 30-40% of people with skin psoriasis get joint psoriasis. You should reduce your salt intake. Salt is known to aggravate psoriasis. Okay. Secondly, as far as skin psoriasis is concerned, it is worsened with tobacco and alcohol, obesity. These are the 3 things that are known to aggravate psoriasis. So you can limit yourself, or you should limit yourself to less than 3 drinks a week. If you can give it up entirely, wonderful. Failing which, if it is part of your life or lifestyle, or you haven't been doing it for years, like limit to 3 drinks. Tobacco, no, not even a single puff. You can't smoke at all. You just have to give it up. Sorry to say that, but however much you love your nicotine, you have to give it up. There are other reasons, more important ones, but psoriasis one is important. And the other thing is, don't treat it like a disorder of hygiene. Trying to rub it, scrubbing, using a pumic stone, loofah, trying to rub it off your skin will actually worsen it. So don't submit your psoriatic patches to friction and excessive hygienic measures. And that's the other thing.
Right, sir. Right, sir. So the next point is, how concerned should I be?
Well, I think we have more or less covered it till now. Worrying about psoriasis is not going to help. The thought that you need to have in your mind is that it will come. When it comes, it will go. When it goes, it is likely to come. And I will also enjoy periods of freedom. If it is very mild, doctor will have taught me how to teach. If it becomes very severe, he has got other ways to deal with it. So it is a contract between you and the doctor who is going to care for you. And that goes on for periods of time. And there are people who go into very long remissions. There are people who don't get psoriasis for 10, 20, 30, 40 years, etc. Like I got a classmate of mine whom I last saw in the late 1970s. And he had a pretty bad psoriasis of the palms. And the thing is, he's a surgeon. He hasn't got it back. At that point in time, I don't know what treatment he received. Our dermatology professor treated him with something. It went away, whatever. He has not had it till now. I mean, like 40 years later. So there are long remissions, but they are not the rule. So you don't need to be too concerned. You need to be knowledgeable. That's more like it.
Correct, sir. So the next point is things to check or look for.
The most important thing you need to look for is joint pains. If you find any part of your body, especially the fingers swollen, or if you find the tendo Achilles, you have got your heel. If you touch your heel, just above the heel,
Yes,
there is
sir.
a tendon that is called as a tendo Achilles or the Achilles tendon. If you get pain or swelling over there, that is a sign. If you get pain or swelling around the joints, that's another. The commonest kind of arthritis that you get in psoriasis is sacroiliitis, that is low back pain. So if you have or had psoriasis and you get low back pain, you need to have it looked at by telling the doctor that you have or had psoriasis, so that they will think of psoriatic sacroiliitis. And psoriatic joint pain is treated differently as compared to the other joint pains. Okay, and taking painkillers is not an answer because many painkillers worsen psoriasis.
Correct, sir. Next point is when to report or see a doctor.
Yeah, if your patch is suddenly increasing in size, if it becomes itchy, if it becomes oozy, and the most important warning sign is if you develop any pus boils anywhere on your body when you have psoriasis, or if you develop an infection anywhere in your body, it could be in the skin, it could be in the nose, lung, joints, eye, anywhere. Any infection anywhere in the body can flare psoriasis. So if you develop an infection anywhere in the body, please report. If you develop pus boils in the absence of any infection, it could be indicative of a very severe form of psoriasis called pustular psoriasis, which can go on to become life-threatening. So if you see pus boils which are not painful, which are probably not infectious, it could very well be pustular psoriasis. You need to see the doctor. If you notice that your patches are suddenly becoming itchy or increasing in size, yes, and joint pains, report. And the other thing to look out for is that if you are in your middle age, past 30s or in your 40s, if you're doing your annual checks, you need to keep an eye on your blood fats, number one. Two, keep an eye on the ECG and heart health, number two. And that's about. And the third thing is if you feel very depressed, because depression and suicidal ideation is more common among people who have psoriasis. There seems to be a shared genetic basis for this. So if you suffer from severe depression, which may be or may not be related to your illness, you need to speak to the doctor and tell him, I am feeling unusually sad, unnecessarily sad. I am getting some funny ideas, suicidal ideation and all that. Especially if you get suicidal ideas, you have to discuss it with your doctor. It's very important.
Correct, sir. So the next point is implication on to general health.
Yeah, like I told you, metabolic syndrome, diabetes, hypertension, heart disease, stroke. These are all risks which are slightly increased in patients with psoriasis. So your annual health check and keep your body weight as far as possible close to ideal. Failing which, at least stay within your correct BMI. Your BMI is very easy to calculate. Go to Google and in the search box put BMI calculator. A window will open up. In that, you put your height in centimeters and your weight in kgs. It will show your BMI. It should be below 30. Okay.
Correct.
It's as simple as that.
Correct.
25 to 30 is okay. Beyond 30 is a risk factor. Keep it closer to or below 25. That is even good. 25 to 30 is overweight. Slightly overweight or normal is where you would want to stay. That's the one thing watching. So which means check your weight regularly. Of course, beyond a particular age, your height won't increase. So check your weight regularly, do your annual health checks. If there's anything abnormal, report it to the skin doctor with whom your psoriasis is being dealt with. So this is the way to go about it.
Mm-hmm. So the next point is how to measure it.
You see, it is like this. If you look at your palm, I want you all to look at your palm right now. And the part of your palm minus the fingers. Okay, there is a part from where the finger of your palm begins. So you omit that. And the part of the palm without the fingers, minus the area of the fingers, just the central palm, that represents 1% of your body surface area, okay? So put your hand on a piece of paper and with an ink, you put dots between your fingers and you put a dot on either side of your wrist. Now take off your hand and connect all the dots and cut out that piece of paper. That is 1% of your body surface area. Keep it as a reference if you're a psoriasis patient, okay? Now up to 3% of the body surface area is mild psoriasis. Okay. So 3% to 10% is moderate psoriasis. 3% to 10% is moderate psoriasis. 10% and above is severe psoriasis. Now, what is the implication of this? Now, mild psoriasis is treated with local applications. Moderate psoriasis can be treated with local applications. And if you have got joint pains, it is called severe and you have to receive medicine by mouth or by injection. And up to 10% of the body surface area, if you don't have joint pains or if it is not on the palms and soles, you can still continue to treat with local applications. But if it is beyond 10% of the body surface area, it is unlikely that local applications will be adequate or safe. You will need to receive medicines either by tablet or injection. That is the implication. So knowing how to measure your body surface area is one thing that you can do simply, easily on your own at home. You can keep track of it, and as and when the area increases, you can report to your doctor and let him decide.
That was quite informative, sir. So the next point is
Yeah.
name of sir.
Sorry, I didn't. Could you repeat the question?
Name of psoriasis in various Indian languages.
Oh yeah, that is something that our advocacy group has to do, because in each language of this country, we have got different names for psoriasis, and most of them are derived from its description in the Ayurvedic literature. The many people are familiar with those names, and in some these languages we may not have a word for psoriasis, in which case we simply have to call it psoriasis. But in each of the languages we do have some name for it. It is worth knowing those names and listing them and making them available to the patients, or asking them to go ahead and find out and tell you and make an information bank out of it.
Correct. So we go to the next slide, sir. It's on patient access. So the first point is who is qualified to treat psoriasis?
That is clear as daylight. As of now, it's a dermatologist who is most qualified to treat psoriasis. When the information age becomes a lot more mature than it is today, and when most doctors can treat most diseases that don't require surgery, there will come a time that any doctor should be able to treat it. But as matters stand today, it's a dermatologist who is going to treat psoriasis.
Correct. The next point is how to spot a nearby psoriasis specialist.
Yeah, you go ahead and Google and put dermatologist, and when you put in dermatologist, lots of people who don't have the qualification or who are not studied dermatology, their names also will pop up depending on the site. So you should know that they have got an MD in dermatology. They will also either MD or they will have a diploma, that is DVD. It's called DVD. In some places it is called DDV. In some places it's also called DDVL. And in a few places in Maharashtra, it's called FCPS dermatology. Okay, so they should have one of these degrees, and you should call and find out that that person has actually learned dermatology in a medical college which teaches that subject at the postgraduate level. Okay. Yes. So there's a lot of confusion and quackery. Simply people call themselves neurologists without having been to medical school, or a dermatologist without having been to medical school. So don't be misled. Find out the degree. If you want, you can speak to the doctor's assistant or the doctor and ask them where did they study. And then you go on consult him or her.
Sure, sir. The next point is, can anyone other than a dermatologist treat psoriasis?
Dermatologist is the one who is best qualified to recognize and start off your initial treatment. And if he finds that you are not responding as well as you need to, then he will take the help of other doctors to figure out if there is something else happening elsewhere in the body, such as a gynecologist in the case of a female patient, a pediatrician in the case of a child with psoriasis, or an internal physician in a patient who may be very obese and have metabolic syndrome and be on multiple medications, may want to check what drugs are safe or unsafe to use on the psoriasis patient. Okay, if a psoriasis patient has got tremors or abnormal movements or epilepsy, he may want to consult a neurologist to see how we can safely treat his patient. A gynecologist in case of a pregnant woman to see what medications are safe in pregnancy and so forth. So things like that. They will take the assistance occasionally, but then the sheet anchor of treatment remains the dermatologist as of today.
Correct. So this is partially an answer for the next point as well. I'll speak out. Is the help of any other doctor other than a dermatologist needed at times to treat psoriasis?
Yeah, the one answer to that is rheumatologist. Many a time what happens is when a patient comes with arthritis of multiple joints, and all the tests for all the other arthritis come negative, and we have see some doubt in the corner of our mind that this psoriatic arthritis may not be psoriatic, then we often take a second opinion and get the rheumatologist to advise us on what is the best course of action to take, which is the most suitable drug, and so on. So we do, if there is one specialist whom dermatologists most constantly contact in regard to a patient with psoriasis, a rheumatologist.
Correct, sir. The next point is there a place where all these doctors are under the same roof, unless by metro states, capital and DHQs?
Yeah, see, it is like this. Number one is corporate hospitals, but those are confined to the metros. The next best bet is medical colleges. Medical colleges are found up to district headquarter level. There's a very big proliferation of medical colleges, and most of them will have most of the specialties which are required. Dermatology will definitely be there. That is the second one. Third one is, again, in the cities as well as the metros, you will have polyclinics where you will have multiple specialists under the same roof. So these are the things that come to mind.
Correct, sir. So we'll go to the next slide, which is on patient cost. The advocacy organization should be able to give ballpark figure estimates. So the first point is consultation costs.
That is available directly on Google today. But then if you go and look up Google and go through that, the person you consult may not be a dermatologist. So the safest way for you would be if an advocacy organization, psoriasis advocacy organization, can maintain a list of doctors who actually are qualified dermatologists, and if they can put up the consultation charges on their side, that might be a safer bet. Shall we go to the next question?
Yeah, I think we lost Rajat, so I'm going to ask. The next question is cost of local applications, that is creams and ointments.
Yeah, this you can, as of today, I mean, this was a question more than a year ago. Today, you put the name of any cream on Google, all the online pharmacies who sell it, the prices will show up. So that's not an issue at all. In fact, many of my patients sit outside in the outpatient. They put the names of the drug, because I print all my prescriptions, I don't handwrite them. They type in one by one and find out the cost. Many a time what they do is they just take a picture of it, send it by WhatsApp to the regular pharmacist, who will give an estimate to them back by WhatsApp. So that is not a big challenge at all today.
Thank you. Cost of biologics.
You see, it is like this. As Matt said, let's be very clear. Manufacturing a biologic is a very, very complex process. And there is a huge amount of wastage, and the whole process, starting from the day of manufacture through to the time it enters your body, has to be maintained in a cold chain. So the logistics of it is extremely complex. And the thing is, these are all complex macromolecules. You know, they will have primary, secondary, and tertiary conformational protein structures. So there is no way you can make a biologic like you can make a tablet. Now, having said all this, it implies two things straight away. The cost of a biologic will never come down drastically like the cost of a tablet. If a tablet is like 40 rupees today, you can expect it to be in 5 or 6 years to be 3.5 rupees or 2 rupees. That cannot happen to a biologic, because the process itself of manufacture, storage, movement, and even introduction into the body through a loaded syringe, etc., is expensive. So as matters stand today, the cost of a biologic treatment per annum for 1 year is in the range of about 1.75 lakhs to around 3.5 lakhs per annum. Okay, and the dose varies depending upon the biologic chosen. So that is there. But then price variations do occur, and if the volume of manufacture goes up, the price does come down to some extent, but not like vaccines. Vaccine prices can come down to rock bottom levels, but biologics are not produced in those quantities, so we can't expect that. This is something we need to know.
So just related to that, do we have a lot of biologics, or just one or two that are available?
No. See, basically, we have got two groups of biologics available in India today. There are three groups worldwide, of which two are available in India. Two groups. In one group, we have got three drugs. One is infliximab. One group is called TNF alpha inhibitors, in which we have got etanercept, infliximab, and adalimumab. Okay. Then there is another group called as interleukin-17 inhibitors, in which we have one called secukinumab and the other called ixekizumab, which will be introduced this month.
Okay.
Okay.
Oh,
So
okay.
as of now, we have 4. We will be having the 5th one for psoriasis in a very short while, maybe a fortnight to a month. So our list will be 5, 2 groups.
And none of these are available through government machinery. They're all available only out of pocket, right?
It's like this. The government doesn't manufacture any of these. Of course, they don't manufacture any drug, in fact. But the point is like this. There are some state governments which in the past have made biologics available to their patients. Tamil Nadu, for example.
Oh,
Now, the central government health service patients, they get their biologics. The armed forces get their biologics. The Indian Railways get biologics. So there are a few select areas where biologics is available through state-backed funding.
that's very interesting to hear. That means there is an opportunity to advocate for other areas as well.
Yeah, it depends on the severity. See, advocacy basically depends on being able to define the morbidity and mortality of an illness. Okay. If you've got a very poor patient suffering from a curable cancer, advocacy is not difficult.
True.
Okay. Now, psoriasis does not spare any particular class. People across the financial spectrum get it.
Yeah.
And it doesn't kill, but it makes life not worth living in about 20% of the people who have it.
Yeah.
So if we have to do effective advocacy, we need to be able to quantify economic loss to the country and the individual and the tax revenue system, and tell them if a person has got psoriasis, you are going to collect this much less tax. So you spend a little bit. We need to be a little blunt. Yeah.
It's an interesting way to put the things across.
No,
I'm
we
not
should,
sure.
because
Yeah,
the people with whom we advocate won't understand disease or a patient suffering, but money they can easily understand.
that is true. I agree completely. So the next question is, if a patient has to be hospitalized, what kind of costs would that involve? I know it would depend on the duration of hospitalization, but something, a broader picture.
Yeah. So the one thing which we need to look at in terms of a lacuna of information in this area is that psoriasis hospitalization, generally speaking, does not involve any surgeries. So there is no such thing as, you going on with a steady bill on a daily basis where you are spending a few thousands, and one fine day you go into the theater and come out and find that it has become like logarithmically large. That won't happen. So it's essentially a medical care. So your hospitalization cost in psoriasis will be somewhere in the range of somebody who is admitted for diarrhea or some other medical disorder.
And does insurance cover psoriasis treatment if it's in hospital?
Hospitalization, generally most policies do cover these days, but as an advocacy agency, you need to look more deeply into it. Because from my personal experience, the moment you say skin disease, people automatically classify it as frivolous. They don't know that skin diseases can also be life-threatening.
Yes.
So we need to collect enough information on the life-threatening aspects of psoriasis.
Okay.
And then put it forth. We can actually prepare a few handful of dermatologists can prepare a compendium on life risk from psoriasis. There are two life risks in the sense that generalized pustular psoriasis and exfoliative dermatitis are two conditions where there is actually a risk to life. Patient can die of it. That is one situation.
Yeah.
Rare, but yes, it is there. And the other one is if psoriasis is poorly managed, even if it is extensive psoriasis, it is not immediately life-threatening. The severity of the disease itself and occasionally the risk of the medicines, risks induced on the target organs by the medicines over a period of time can actually overall reduce the lifespan of a psoriasis patient. Today, it is well accepted and documented that a patient with psoriasis, severe psoriasis, lives for actually 10% less time than a control who is healthy or does not have psoriasis. You understand? So psoriasis reduces lifespan too. It can be acutely life-threatening in certain situations.
I am not too happy to hear that because I have psoriasis too.
No, but it is like this. 80% of the people have got mild psoriasis, meaning to say that which affects less than 3% of the body surface area. There, the risk is not high.
Okay.
I'm talking of people with moderate or severe psoriasis who require medication by mouth or by injection for protracted periods of time. There, the risk is high. The
Okay.
risk is imposed by two things. Number one, the severity of the disease itself, and number two, by the medication used for it. Now, the
Okay.
medication used for it component can be brought down significantly when we use biologics, which is the reason
True.
why biologics are more or less the first line of therapy for severe psoriasis in the Western countries.
Yes. Yeah. So, yeah, but it's still, worrisome to know that it has an effect on lifespan as well, because as you said earlier, there are
Of course
remissions
it
and
does.
there are periods. Yeah, there are remissions and then there are periods where it will come back. Okay. So next slide, please. Psoriasis advocacy for doctors. So
Yeah.
where can
What
doctors
does it
find
say?
guidelines and articles or new guidelines for newer medicines, etc.?
I'm sorry, could you say that again? I couldn't hear you properly.
So this slide refers to psoriasis advocacy for doctors, and the first bullet is guidelines and articles or new guidelines for new medicines that can be made available to doctors.
Oh yeah. You see, a doctor, even a dermatologist, has to handle like 30 different diseases, skin diseases every day. Okay.
Yes.
So what I have to say here is that to prevent a doctor or to encourage a doctor to remain up to date, an advocacy organization can constantly harvest all the guidelines which are published by the different professional bodies all over the world, as well as by psoriasis or dermatology groups in different countries of the world, and maintain a library of latest guidelines, and keep sending those guidelines to the doctors in both full text and summary form.
Right.
Most of the doctors will read the summary and get the hang of it because they have been treating the disease for, from the day they
Very long
qualified.
time. Yes.
So there will be first a summary and then the full text for such people who would want to read the full text. So this will be the one of the jobs. Like for example, the National Psoriasis Foundation does this. If you are a member of the
True.
NPF,
True.
you keep getting things in your email, so that every day you just pop it open, see how much you want to read for you to get the hang of things and continue. So an advocacy group for psoriasis should be doing this in order
True.
to not prevent misinformation, but in order to curtail outdated information.
I agree. And just a related question to this, though it's not there in the bullets. Do we have enough research that is India-based to give us an idea of what is the burden of disease or the epidemiology of the disease?
Yeah, it's reconnected. Please go ahead. Ask me the question.
Yeah, so the question was related to these guidelines and updation. Do we have enough research that is local, meaning India-based, to give us a good idea about the burden of disease or the epidemiology of the disease?
Yeah, there are. All you have to do is go to Google and put psoriasis and India and guideline. You will get it. I think our last guideline was published about 2-3 years ago, and there are people working on it on a constant, on ongoing basis. So we do have local information, but the thing is, since we don't have a online electronic health record system like in the Western countries where data is available immediately on hand, we don't have that wealth of data. But having said that, I'm extremely enthusiastic about the advent of ABDHM. You must have heard of
Right.
no Akhil Bharat
Yes.
Digital Health Mission.
That's
Once that falls in line, let me tell you, once that falls in line, health information will move as swiftly as money through UPI. It will have a leapfrogging phenomenal effect. I only hope they understand what a significant thing it is going to become and work at it assiduously. The earlier we have it, the better it is for us.
Thank you. And sir, one more question regarding that. Do we have disease registries in India?
No, not to the best of my knowledge.
Okay.
But once
And
we
that
have
is,
something like this platform, automatically it will act as a registry for all diseases for all people all over the country.
I hope that they understand the scope and then they use it to its full potential.
Yeah, you can write to Mr. Mansukh Mandavia directly because I have written it to him as an individual and I got a reply.
Okay.
Looks like they are good, they're quite interested. But if you write as an organization, especially as an organization with a petition signed by all the people associated with like 500,000 signatures, then that will have a real impact. You should talk to him and then send him something in writing and push him along so that at once we will have a universal registry for all diseases all over the country. It will become the world's biggest registry then.
That is true, sir. And that's a wonderful idea. Thank you for that.
Yeah.
We will immediately do that. because we
Yes.
already have a cohort of patients who are our members, so we can start something with them, if not, for the whole country. So
No, the whole country is what we should aim at. It's a big goal. We should go for it, and because it can happen.
yes,
It is
I
started with
agree.
that intention. The thing is, they don't seem to have understand what the implications of it could be.
That is true.
Unbelievable. We will have a system which is not in existence anywhere in the world.
Yes. So yeah, I will do that. Thank you for that suggestion. So the next bullet is disease severity assessment training.
Yeah, I told you just now. We can simply teach body surface area, which is the simplest thing. And there are other systems which can be done at home by patients, which are described, which are available, the resources available online. But body surface area is a very good, simple, easy to follow guideline. If there are other things, we will discuss it in the future. If we need to develop instruments to hand over to our patients, we need to look into it. But as of now, the palm size is a good thing.
And quality of life assessment training and instruments.
That is for the doctors.
Yes.
Yeah, because this slide is about the doctor. Sorry, I thought we were still talking of patients. For doctors, we need to have they need to do a PASI on every psoriasis patient. PASI is psoriasis area and severity index.
Right.
And every doctor should have on his desktop, meaning to say the computer desktop, the DLQI, Dermatology Life Quality Index, both of which are freely available online.
Mm-hmm.
Yeah, it is just that PASI and DLQI should be measured for every patient with psoriasis. What we do is a very rough global assessment. Is it itchy? Do you have joint pain? How do you feel? Has it become more or less in area? Has it become less red, thick? Do you have any bleeding spots, things like this? We do a rough estimate and carry on. We are happy, patients are happy as long as the treatment is working fine. But I think we should go into, because the rheumatologists are very assiduous at this. They follow the ACR 20, the ACR 50, the ACR 70, and all that. They do regularly on every visit for every patient. So, with regard to psoriasis, I think we should do this. PASI and DLQA at the very least. There are other scores for localized areas of psoriasis, but at least for the ordinary psoriasis, we should do PASI.
Thank you.
PASI and DLQI.
Yeah.
And the way to, we just need to remind the doctors and then give them links as to where these are found online. I mean, anybody can find them. It's just that we need to egg them on a bit. That's it.
Sure. So that's maybe one thing that we can do, send reminders. And then the next bullet is templated counseling tools in different languages.
Yeah. See, when I talk of, it's like this. When a patient comes for a first consultation and the diagnosis of psoriasis is made, the whole funda about the disease should be made explicitly clear to the patient. So what I have done in my practice is I have made a video which encapsulates the whole story of psoriasis, about its remissions, exacerbations, different parts of the body, arthritis, metabolic disorders, that is consulting other, everything. The whole gamut of information is put into one 10-minute slide, 10-minute video. And what I do is I'll tell them that you have psoriasis. I would want you to listen to this video and then I'll answer your questions. So I turn on the video, they watch it, and then if they have got any questions, I will answer that. It is like this. So every doctor has to prepare his own video, or you could prepare one through your organization and in different languages. The script can be given by a dermatologist. You can do it with the help of anybody who can speak well. And that can be distributed to the doctors. It will be an invaluable resource. It makes the management so much easier. Instead of saying things like, oh, it is like, some people are very dismissive. They say psoriasis of the skin like common cold of the nose. Some people will say it is incurable. Some people say you will have to live with it. Or, so all kinds of wrong messages are sent at the first visit, especially in a busy outpatient. Hey, all our outpatients are busy, okay? All the good doctors see anywhere from like 60 to 100 patients a day. How are you going to spend 25 or 30 minutes with one patient? Unlikely. So if you have a tool like this, you can set it up in an adjoining room and have somebody show that video and ask the patient to come back and ask you questions with a piece of paper and pen in hand, so they can note questions as they go along. And the other thing is handouts in soft and hard copy. Soft copy, send it to their WhatsApp or email, and the hard copy can be handed over to them in person. And it should ideally be in the local language. For such people who can't, who have difficulty in reading, etc., the video is always there, but it should be in the regional language. Two choices at least, English and regional, or things like this.
We can certainly work on this, and we will get back to you on how to, because the pamphlets and some handouts we already have. The videos we can develop, not be an issue. So this is for the pharma industry,
Yeah.
and it is talking. I encourage local production. This is quite clear, the message. The second one is inclusion under DPCO.
Yeah, we would like to have as many drugs which are given by mouth for psoriasis included in the DPCO as possible in order to render it affordable, because the numbers are huge. 2% of any country's population will have psoriasis. And out of
So
that, around 20% will have severe psoriasis.
yeah.
Okay.
So
So 20%
DPCO
of
would be
2%, drug price control
DP.
order.
No, I understood that. I just wanted to expand on it so that others understand. Yeah.
Yeah, drug price control order.
Yeah. Under NPPA,
I
National
don't know.
Pharmaceutical Pricing
Yeah,
Authority. Yeah.
correct.
Yeah. Okay. So, and then development of biosimilars. Do we have any existing biosimilars?
Yeah, we have got one for etanercept, we have one for infliximab. In fact, we have one for adalimumab. That is all the TNF alpha inhibitors. We have got biosimilars. For the interleukin 17 inhibitors, that is secukinumab and the forthcoming ixekizumab, we don't have biosimilars as yet.
So, are
So for
these
three,
biosimilars manufactured in India or some other country?
no, India, they are made here.
Oh,
Yeah, and they work out to be
fantastic.
marginally cheaper. Like I told you, the process itself is complex, so you can't expect it to become rock bottom. But
Hmm.
compared to the original molecule, it is definitely cheaper, and they are as effective.
Okay. And then there's a bullet on funding academic centers and researchers to discover new disease pathways and drugs.
Yeah, like for example, on a regulatory basis, if we can make such a fund tax exempt, and if such a fund can be correctly guided and monitored, see, we have lots of people doing MSc and MSc PhD and things like this, right? In the basic science,
Hmm.
we need to find out what they are working on, and is it leading to anything which is concrete, especially in the biological sciences. So these are the bench researchers who will discover disease pathways and molecules and tell us this is what happens in this disease, and if we interfere here, maybe it will cause. And there are animal models for psoriasis.
Yeah.
So at the cellular level and animal model level, we'll give a demonstration, then go to phase 1, phase 2, phase 3, etc. So my own thinking is by 2033, if we put our resources and brains together and work at it properly, we should have a very good molecule for psoriasis, either given orally or by injection. 2033 is the kind of figure that I have in mind, but it's just that we need to connect the dots and see how we can finance and direct these people's skills in one direction. In this case, in the direction of psoriasis.
I don't know the pathway for it, but it sounds very interesting.
Yeah,
And
we should think about it. We should think about it and see how to work it out. We should look at models in the West, how the academic complex, academic industry, university industry,
yeah.
connections work, how the funding is channelized and all that. These are the macro view things.
Okay. Then the last, I think, slide, because this is labs and diagnostic centers, it is talking about packages for pre-treatment and pre-acetretin or pre-biologics, etc.
Yeah, like for example, we got packages, right? We got a diabetic package, anemia package, etc. For in the labs there. So we can also ask them to make packages, because when you are giving any of these drugs, you need to check for a certain set of things to make sure that the body can tolerate the drug properly.
Yes.
So
Yeah.
we can ask them to make a package for methotrexate, one for acetretin, one for any other drug that we wish to use, one for biologics and all this.
Hmm.
So we simply write that package, and once it is made into a package, then we can talk of costs.
Interesting. So, okay, so this is another point that we will discuss with you. And of course, if there is arthritis as well, then radiological assessments, ultrasounds, and other
I'll tell you,
assessments.
because there what happens is, I'll tell you.
Yeah.
Assessment, you do a baseline assessment, you treat the patient, and at 3 or 6 months, you repeat the radiology.
True.
Okay.
Yeah.
Because what happens in the joint treatment in psoriasis, there are some standard drugs which have been used over the decades where the joint pain and swelling go away, patient is comfortable, but the joint destruction actually continues.
Yeah. And that is only visible
Okay.
when we do a repeat radiology.
Whereas in the case of biologics, that doesn't happen. it not only reduces the inflammation, relieves the pain, but it also keeps the joint functional. So when I'm talking of radiology packages, what I'm talking of is you charge the patient once, like for example, if I were to do the MRI of the shoulder, okay, it'll cost around 3,500 rupees. If I repeat it a second time to check the improvement, it'll cost me another 3,500, right?
Yes.
So if I say psoriatic shoulder or whatever joint package for 2 pre and post at an interval of say 3 months or 6 months or whatever, instead of paying 7, if they could give it to me for 6, 5 or 6,
Yeah, then
you know,
it reduces
so
the
you
cost.
just pay once and you don't have to think of the cost a second time. The like in a farming contract, the cost is sealed and the service is guaranteed, and you may make a small saving. That kind of thing. That's what I meant by package.
Oh,
Yeah,
again.
because we also measure joint pain by ultrasound. There are very few people who do it, but it's a very precise and good method. So we can work out packages for that as well. And once you do the packages, the numbers will go up, the utility will go up, the utilization will go up, the outcomes will go up.
True, and also people will be more adherent, meaning they will not drop out from the system.
Exactly. Once you have paid for it, why would you want to waste it?
Exactly. That's again very interesting concept. So we will sit and discuss all these ideas with you, sir.
Sure.
So we come to the next slide, which is advocacy with insurance companies, and this is financial benefit to company by covering outpatient care.
Yeah, because you see, there are many people who are treated as inpatient today simply because insurance asks them to. But if the same condition can be very well treated outpatient, and the
Yes.
reason why we don't do it is because the insurance won't cover. But if the
Yeah.
insurance were to cover the outpatient, the payout they have to give to the patient will actually become less. That they need to understand.
Yeah.
So they are running their, what should I call it as payouts, depending on some idea which is at least 2 decades old.
Yes.
That
Some
we need to
companies,
communicate to them with concrete examples.
yeah, some conditions I think there is a change,
Yeah,
but
if some companies are
dermatology,
doing outpatient,
yeah.
yeah.
Please go
So
ahead.
in dermatology,
Yeah.
once we learn how to quantify the severity of the illness, then it will become easier for us to do this. That's why where the measurement scales come in. You know, the PASI and the DLQI I was referring to earlier, if it becomes a routine, then we know.
And I think related to the same thing is exclude psoriasis as a criterion for rejection of policy or payment, or reduce the waiting time, if you're
Yeah.
purchasing a new policy.
Yeah, because many people who get psoriasis don't know they're going to get it because they haven't seen or have heard or that there is nobody who has psoriasis. And psoriasis can suddenly start off one fine day. And then if you have to wait for 1 year before you get coverage, what's the big fun? I mean, it's not as though you had a road accident by rash driving or something. It's not that way.
Yeah.
Such a patient
Yeah.
is completely innocent. I raise this
Yeah.
issue because I've had problems like this. Patient takes out a policy and he thinks he's covered for everything. One fine day he comes with severe life-threatening extensive psoriasis covering the entire body. Poor guy, what is his mistake?
True. And
And
it
the
is not
company
pre-existing.
claims, yeah, it's not pre-existing. It was not brought on by will or any kind of misadventure on his part. He's in no way to blame.
Yeah, I agree. This is one
And
big area that
yeah.
needs. Yeah. This is again something that we will have to work out with IRDA probably.
Yes.
I'm really sorry. My laptop just decided to get to die, but I'm back now. I can take over. Thank you, Dr. Ratna, for taking this and taking this forward. I'm really
Is there
thankful.
any question left? I think there are a couple.
Yeah, there's one for the government. So the questions for the government is guide patients on how to tap into MLA, MP, BPL, and such funds.
Yeah, many a time patients come and especially those who require expensive medication or hospitalization, These members of the Legislative Assembly, members of Parliament, they will have actually some funds. And there are some hospitals in Bangalore who have figured out who you need to speak to and how to route the request so that these funds are actually spent on people in the constituency who really need it. So the advocacy group can also take a cue from these people and learn how to do it, so that if there is a person who is really stuck, no insurance, not too well to do, not under any particular scheme, etc., how to help them out, and how to exploit all the benefits of BPL card health benefits, because most of the BPL card holders may not know what all it entails, in the sense what all the benefits it has to offer. So we need to kind of egg them on with regard to how to make the best use of it in case of a situation where the psoriasis is really bad and its care requires a certain degree of intervention, which is more than just an outpatient visit.
I agree. And then also introducing patients to Janaushadhi Kendras.
Oh, that is something fantastic. I mean, Janaushadhi medicines are really good, let me tell you. I can say that today with full confidence. Absolutely no problems. And cost is anywhere from 1/6 to 1/10. Not even percentage. It is 1/6 to a fraction. Fabulous. So if you are looking at somebody who requires prolonged medication, if you have to go on, say, methotrexate for a year or cyclosporin for 6 months or 3 months or something like this, Janaushadhi is really reliable. Makes a huge saving.
Yeah, the only caveat is that Janaushadhi is not strong in all states. So where it is strong and available, it is a very good option.
You just go to the website. It will guide you to the nearest Kendra. It will give you the addresses of all the centers in all the districts.
Yeah.
They've got a website. So yeah, through the website, you can locate where they are.
And I love this last point that you have, jotted, which is facilitate rapid duty-free import of biologics on named patient basis for those not available in India.
Yeah, like for example, say there's an occasional desperate patient uh, who doesn't respond to anything which has been used so far. This is a rare situation, but can happen. For such a patient, where he is at the end of the rope and a doctor is also at the end of his rope, poor guy, we should be able to import the biologic. Somehow the money can be arranged, but if you have 60% of it as duty and all that, I mean, at least there, we should have some mechanism by which, if a doctor says that the following things have been done and everything which we have in our kitty have proved useless, this is the one thing that I want from abroad, it should come in duty free.
This can be done, sir. We've done it for other rare diseases and disorders. So the same procedure can be adopted for psoriasis or rare
Fantastic,
psoriasis
great.
or life-threatening psoriasis.
Fantastic, great.
Next slide, please.
Dr. Ratna, I can take over from here.
Yeah, thank you, Rajat. Over to you.
Yeah, I think there's only
for having my back over here. My
Yeah.
computer is died. Really
Okay.
sorry for that. I'm really sorry
No problem.
for that.
I guess we got only one slide left, and then maybe a few questions from the audience.
Yes, sir. So the slides is on regulatory agency advocacy. Guide and assist doctors on how to set up ethics committee in hospitals so as to form a basis for observational and interventional clinical trials.
Yeah, so if you go to the ICMR website, it gives you complete guidelines on how to set up an ethics committee. But then for people who have never done it before, who don't have an ethics committee, they will require a little bit of hand holding, especially in large private hospitals who have got a good throughput, but who have never thought of converting their data into clinical research or publication. If a NGO can do that, if you can put together the skills required to handhold people till such time as an ethics committee set up and run, that will be a really great service. It will benefit Indian science at large.
Correct. So the next point is guide patients with psoriasis to nearby centers where clinical trials are underway.
Yeah. So if you gain access to the clinical trial registry, which is not difficult, and you find that here is a patient, here are doctors trying to recruit patients, because their ambit will be very small. They won't know how to inform patients that there's a trial going on.
Correct, sir.
And then the patients are also looking for new therapies or trying to get into a center where they're enthusiastic about participating in a trial, which is cleared by an ethics committee. So putting these two together, it could be a very good thing for an advocacy group to do.
Correct, sir. So, and probably people are not very much educated about the clinical trials and all
Yeah,
these
they
kind
use
of
the
things.
word guinea pig, that's ignorance. No. You go to a clinical trial, you're not a guinea pig. By no stretch of imagination, you're not being experimented upon. There's a very rigorous consenting process. There's an
Correct.
ethics committee in place. And these days, there are hardly any fully placebo-controlled trials. There is a placebo arm, but there is no way you are going to receive a placebo throughout the trial and be permitted to suffer. That doesn't happen.
Correct, sir. The next point is, if newer drug trials have been carried out abroad on multiple ethnicities, including Indians, diaspora in significant numbers, the clearance for those in India needs to be short, easy, and swift.
Yeah, like for example, when a company makes a drug application, for a new drug or a drug which is not currently available in India, and a multinational company or a drug invented in another country puts it up for marketing here, they should actually look at the ethnicities of the participants. In which
Correct.
case, if you can simply, say, okay, fine, there are a good number of people from Southeast Asia or from India specifically who have participated in statistically significant numbers, you can simply waive off the Indian clinical trial, especially if it has got a good safety. If a drug has been administered over a 5-year or 8-year period, and in the original clinical trials, a good number of people from India, Sri Lanka, and etc. surrounding countries have participated. If they are recorded by ethnicity, I don't see why we have to do another phase 3 trial in this country simply because it's a regulatory requirement. I mean, the regulation is put in place in order to assure safety, but a regulatory requirement must not become a regulatory burden.
Correct, sir.
Yeah, because the clinical trial cost, etc., will again add up to the cost of marketing the drug, and it actually the patient ends up paying for it.
Correct, sir.
This is
Correct.
something we've been fighting for atopic dermatitis. So, I mean, the drug is not getting registered, and we did a say qualitative study, semi-qualitative study, submitted the report to the Drug Controller General, still fighting to get the drug registered in the country.
No, it's not that way. See, like for example, Japan. Okay, any drug doesn't matter if it has been used for 25 years in 1 billion people, unless it is Japanese subjects, they won't let it in. They are uncompromisingly rigid. We can also be that way. But the point is, if one were to look at it another way, if good number of people who represent our ethnicity have already participated in the clinical trials and in the post-clinical surveillance, and there is a record of a good number of our people having received it with a good safety profile, if the numbers add up, we can take the help of there are any number of excellent statisticians in this country, and we can set some kind of a statistical bar, and if it passes that, we can simply say, okay, fine, this is permitted for use pending the clinical trial at a later date. So let the company sell the drug, make some money, and then fund a clinical trial. At least give them a 1-year window, no?
True,
And let the
true.
patients get the benefit of it. Yeah, I'm not saying just take it off. Give them some time.
It's not happening, sir. We have been fighting for 2 years now, but good to
It
know that.
requires a little bit of mindset, and we need to be a little convincing in our argument. We say, if you keep on insisting, give, they won't. If we tell them, give for this particular reason, this is how we look at it, this is one way of thinking of it. If we can help them open up their mind, then they will. Otherwise, they'll be simply stuck because they are not doctors, they are not patients. They don't have to face one sad fellow sitting with psoriasis all over his face in front of them. They're not in that situation.
True. I completely agree. Also, it needs some internal advocacy, because in this case, what happened was the dermatologist who was the head of the technical group on behalf of the government wrote a negative report, whereas all other people wrote a positive one and recommended that it should be registered in the country. So just one person's comment, because the person happened to be from a very senior position in a government medical college, sort of delayed the registration, or at least the registration hasn't happened so far. So I think some internal advocacy with our specialists is also very necessary.
Yeah, it is. It also it depends whether in a government medical college in which he comes, have they used any biologic for any disease at all?
Not at all, sir. That is the whole.
Then how can that person give an opinion?
No comments.
It's as
And
simple as
Rajat,
that. No,
over
really,
to
we have to
you.
know. We have to speak of this openly. We
Yeah,
have to speak of this openly.
yeah.
We don't, we don't save patients' lives by designation.
True, true,
We
true.
save the patients' lives by knowledge.
I completely agree.
So
Um,
further is the reading material which you have mentioned over there, PubMed and other text for patient for psoriasis.
Uh-huh. Yeah. So for all the patients, or for all the people who are interested in psoriasis advocacy, I have put in a set of PM IDs. You go to the website called pubmed.gov
Yes, sir.
and put only one of those numbers, one at a time. Don't use the word PM ID, just put in that number. An
Right,
article
sir.
will open up. It's a free full text article, scientific article, okay?
Right, sir.
So all these are PMID numbers of articles that deal with advocacy in psoriasis. So if you want scientific inputs for advocacy in psoriasis, these PMID numbers will help you. You can get started with this and take it forward from there. These numbers can be used by anybody with a little bit of science knowledge, or if you wish to give it to your doctors to have a look at it from the point of view of aiding you in psoriasis advocacy, that can be done.
Brilliant, sir. This is great. This is great thing. So there are organizations worth emulating. There is
Yeah, I've
national.
given a list of organizations. Put their name in the ordinary Google search box.
Yeah.
You will get their website. Go through those and see the methods they follow, what they advocate for, what's the method they follow, what they have gained, and what are the programs. So they'll get overall. It's a nice way of mapping what
Correct.
similar organizations are doing elsewhere in the world.
We will try to do the similar kind of a thing, but in a much better way. We believe.
Yeah,
Great.
we'll do it.
Thank you, sir. So there are some questions. One of the question is etanercept safe and how it works for psoriasis patients, or scafo safer?
Both are safe. I mean, we have been using both of them for quite some time. Etanercept is very good for people who have got extensive, severe joint pain and mild to moderate skin disease. Now, there is some record that if you use etanercept in a particular dosage for a particular duration, from 12-week onwards through to 1 year, it is capable of giving comparable results. Scafo is also safe. It works on arthritis and skin psoriasis. The onset of action is quite swift. It's got a very high safety profile. Etanercept is also very safe of the TNF alpha inhibitors. The other two TNF alpha inhibitors carry some risk of psoriasis. It is much lesser than etanercept. But if you wish to use secukinumab, which is Scafo, or etanercept, which is sold in as Enbrel and Etacept, I mean, you just look at the cost and go for it.
Okay, so it's majorly based on cost.
Yeah, so
Whichever is cheaper
no,
one.
don't no. Scafo gives slightly superior results if you're looking at skin psoriasis,
Correct.
and etanercept gives superior results if you're looking primarily at joint pain.
The arthritis, the psoriasis
The
arthritis.
arthritis. Yeah, arthritis.
Correct.
Yeah.
Correct, sir. So there is one very interesting question. Some patients have tried using apple cider vinegar to reduce inflammation associated with psoriasis. Is there any scientific evidence to support this claim?
Yeah, there
And
are
if
lots of.
so, how should
No,
it?
apple cider vinegar is not something that we either or recommend or use. But having said that, uh, like St. John's wort, apple cider vinegar, and there are a bunch of things, home remedies of the West, chamomile, etc., which have got some articles published in their favor in journals which address in natural medicines and all that. But to what extent they are reliable or comparable to the pharmacological products we have at hand, and can I sit in a clinic and recommend the use of any of these, I am uncertain there. So my answer to that question is I really don't know. But if you have used it and if it gives you benefit, there might not be any risk in using it. Just make sure that you don't consume copious quantities of it because of it's got a high pH.
So there is this
Low pH.
correct. So there is this one question from Facebook Live. It says, "Is it necessary to remove scales from the body when treating psoriasis?
No,
And what are the
don't try.
best methods of it?"
No, don't try to pull off the scales. Don't try to pull off the scales. You have a regular bath. Don't rub and scrub. Just apply petroleum jelly or a thick
Right.
oil. Petroleum jelly is by far the best. That will neutralize the scales on its own. And as the treatment for psoriasis takes effect, the scales will all shed on their own. Don't try to pull them off.
Correct, sir. So there is one question.
Sorry, Rajat,
Please.
before you go ahead, I had one question. In the lifestyle risks, you mentioned alcohol and tobacco as a big no-no. Does stress and sleep also have an effect, meaning less sleep?
That is very hard to answer, but inadequate sleep definitely causes increased sympathetic activity, and it may in fact worsen all kinds of inflammatory diseases, of which psoriasis is also one. Having said that, it is not very easy for me to go and tell everybody that it is 8 hours of sleep is mandatory for you, otherwise your psoriasis will not get better. I can't say that, because some people are fully rested with 5 or 6 hours. Why would they want to be forced to be lying in bed for 8 hours? You know, so but if
Yeah.
you are in a state of ongoing sleep deprivation of the very many things which can aggravate psoriasis, this could also be one. It's like that.
Also stress?
See, who is devoid of stress today? Everybody is stressed. So
That
it is
is true.
secondary. One is in the absence of psoriasis, you have stress. You also have stress in the presence of psoriasis because of the disease. So if you get rid of the psoriasis, your stress will come down, is my answer.
Okay, thank you.
And sir, adding to that, challenges at workplace, the psoriasis patients they face in their workplace because they get neglected due to social stigma and things like that.
Well, to an extent, you can alleviate it by dressing from, neck to ankle to wrist, so that the patches are not visible while it is being treated. If you want to go to work and wear a t-shirt with large plaques of psoriasis on your elbow, it's a silly thing to do. I mean, you will embarrass yourself and others who don't know. You need to educate them about psoriasis. That's an effort.
Correct, sir.
So till such time as it remits, you dress in a way so that the patches are not visible. Once it remits, you're fine. Nobody will ask you any questions.
So there is this question, like someone has reported discoloration on the skin as a side effect of using biosimilars or biologics for psoriasis treatment. Can you speak on the likelihood of these hyperpigmentation areas regaining pigmentation with continued use of
Yeah, they will regain
the
pigmentation. See,
biologics?
hyperpigmentation can occur with any psoriatic treatment. When the patches disappear very quickly, the pigmentation will be there. It's a consequence of the interleukins which are liberated over there. Every patient who is brown skinned will heal with pigmentation. It is not just limited to biologics. It can happen with anything. It can happen with cyclosporin. It can happen with methotrexate, acetatin phototherapy, anything. Just give it some time, it will come around.
So your views on individuals or organizations who claim to cure psoriasis through homeopathy or Ayurveda, are there any alternative therapies effective for managing psoriasis? Or do you recommend any
Yeah,
conventional?
there are alternative therapies. No, I can't recommend any, but I am aware of the fact that there are alternative therapies and they do induce remissions, and we can't take that remission for a cure, because remissions can be a variable period, including long remissions. So if somebody says that you come to me, I'll cure psoriasis, it clearly means that you're dealing with a con man.
Okay, sir. Correct. There is this one question. How do you see the future of psoriasis treatment in India? And are there any new or any emerging treatments on the horizon?
Yeah, there are. There is a new molecule coming. It will, like I told you, it will be released in a fortnight or a month.
Okay.
See, the thing about psoriasis is, how can you get on with life by spending less time thinking and worrying about it? That's the main thing. Okay, the day when we'll get some kind of understanding into genetics of any chronic skin disease, and we are going to cure it genetically by using CRISPR or some such similar technology, is as yet in the realm of science fantasy. As far as scientific fact is concerned, we can give the equivalent of what we have achieved in HIV, what is like a function injection once a month or 3-4 times a year or 3 times a year, like a vaccine, and you will be clear of your psoriasis, carry on with life. That kind of thing, we are very close to it now. That is foreseeable. In the next couple of years, we'll have all that available in India.
Brilliant. So just one last question. I'm going to take just 2 minutes of time. Some of the patients have reported experiencing weak immunity. Would you recommend any medication to enhance the immune response for the individual?
I don't understand what I mean by weak immunity. I mean, if it is mappable to some particular organ or symptom complex, then I can talk about it. But weak immunity per se, if a patient comes and sits in front of me and say, "Doctor, I got a weak immunity, what will I think of?" It's a difficult question.
Correct. So I guess that's it. We have taken down number of points, and we will be putting many things on social media. And thanking you, sir, on this wonderful session. So thank you, Dr. Krupa Shankar, taking time with us today and sharing your vast knowledge and your experience on the topic of psoriasis. It has been a truly enlightening and educational session for me and for all of our audience. Thank you very much, sir, for your time. And I wish we will.
Thank you very much.
Thank you so much, sir.
Sure. Thank you very much and good night. Bye-bye.
Good night, sir.
Thank you. Thank you. Good night.
Thank you. Good night.